At New York-Presbyterian, how is digital engagement supporting patient-centered care?
So we're doing tons in that area. You've got to be able, again, if you're going to provide good health care, you've got to be available to patients and customers in many modes and in the modes that they prefer. And so we're trying to be a system that gets resources to patients in ways that are convenient to them. That's education about their condition, how to take care of themselves. And then customers want choice. So we're trying to be digital in all directions. Our CEO has said occasionally, like in some ways, hospitals, health systems are technology companies that provide healthcare. So you need to be able to design things in a way that patients and team members, not just patients, but how we even work together, can sort of choose how they want to engage with us, and that option is there for them and readily usable. Remember, we don't even talk about patient experience anymore. We kind of talk about human experience. Everyone in our walls is having an experience, including the people who work here.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Greg Malkery, and joining me is my co-host Keith Washington. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint.
Good morning. Today, I'm really excited to welcome Rick Evans from New York-Presbyterian. So, Rick, if you don't mind, just tell us about yourself, your background, how you got started in healthcare, your role at NYP. Just how'd you get here?
Sure. Well, good morning. It's great to be with you. So my current role here at NYP is I'm a Senior Vice President and Chief Experience Officer for our network of hospitals. And New York-Presbyterian NYP has hospitals throughout the greater New York area. I'm in Manhattan today, but we have hospitals in Queens, in Brooklyn, and up into Westchester. So it's 11 hospitals, about 50,000 employees. I've been in this role here for about 10 years, but it's my second tour of duty at NYP. Back in the early 2000s, I was here for a number of years running patient-centered, patient experience kind of programs and support services, laundry, housekeeping, very important areas, food service, et cetera. I had a little stint in the middle of that, 4 years as the Chief Experience Officer at Mass General. So I've had a career that I feel very, very lucky to have had the jobs that I've had in great institutions. My training is actually not healthcare. I was trained to be a priest. My degrees are in theology. I almost got ordained and at the last minute made a decision to take a different direction. I joke that I'm the runaway groom of the Catholic Church. But a lot of what I learned in that training, I use every single day. How to read a room, how to treat people correctly, how to reflect on how things are done and make them better. So I like to think I've used that theological training through over 25 years now in healthcare.
Well, thank you. Awesome. So can I guess that you're going to root for Notre Dame on Monday in the college football championship? Is that a thing?
No, I wish I could see. I'm a Buffalo Bills fan, so my focus right now is elsewhere, quite frankly.
All right. I got that.
This could be the year after 40 years of therapy.
Oh man, I'm rooting for you.
Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Storage Systems and Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode.
So I guess tell me about your role as a leader at New York-Presbyterian, say with your colleagues on the executive leadership team. Like, what is that like? Like you said, with your background, how does that work with clinicians and more technical kind of colleagues that at your side?
So my job here is to make sure that we're thinking in a very methodical and strategic way about really two journeys, the journeys of patients through our system, whether that's an inpatient, outpatient, et cetera, and the journey of customers through our system. So most of us in our lives at different points, we might be patients in a doctor's office or in a hospital, but many other times we're customers. We're using the web to find an appointment or a doctor to learn more about our health. And so strategically, my role here is to make sure that we understand the experience of our patients and customers, and that we have a strategy in place, interventions in place to both improve the experience when you're in our care, but also to make it more convenient and a better experience for people who are trying to access us. Access is a huge, huge problem, quite frankly, in healthcare. We're really bad at it. We make it hard, and we're trying to make that much, much better here, as are many other health systems. But we're in a market in New York where if you can't be convenient, there's lots of good choices for your healthcare. So we're really trying to work on that. Now, in terms of working with my colleagues, I don't have a lot of direct reports. My division might be 700 or 800 people. Some of my colleagues have thousands of people in their divisions. So my job is to interface with our chief technology officer and transformation officer, our chief nursing officer, our chief people officer, our chief quality officer, to make sure that we've got strategies that are focused on patients and consumers that really are nested and appropriately interdigitated with our people strategy, with our technology strategy, with our finance, our plans for finance and growth and revenue. So my job is really a lot of my job is integration and influencing agendas with my colleagues.
So I guess, yeah, as you're talking about New York Presbyterian, so I think about that culture, and you even mentioned like New York City, Manhattan culture. Yeah. I got to imagine that. So, and you said if you're bad at it, so like the brand promise of New York Presbyterian, I guess, tell us about that. Tell us about that prestige factor that probably goes with your institution, and just that I got to believe expectations are high. How do you reconcile we're bad at it with those kind of expectations?
Expectations are definitely high, and we don't shy away from that. I mean, what makes us great is we have this partnership with two premier medical schools, which I think makes us unique in the country. Mass General Brigham is associated with Harvard. We're associated with Columbia and Cornell, two great medical schools, enormously talented doctors. We innovate in medicine in so many different ways. So people do come to us, and that partnership makes us really strong clinically. And then the hospital is run, I think, very well. But that means people come through the doors expecting excellence, expecting cutting edge treatment, and they also expect compassion and interactions that are meaningful. So we've got a lot to live up to. We don't mind that. And I think we're pretty sober about what we think we do well and where we need to be better.
Excellent. So with that in mind with your colleagues, say one of the things we talk about on our podcast here, Beyond the Blueprint, is about design. And so I imagine you guys are looking ahead into the future and saying, look, if we're trying to design for this future state where we're operating, let's say everything's better or trying to get better, and really trying to have that more integration, like you're saying, the thing you're working on with the integration, with your influence, really like being that voice of the patient. How do you guys see that playing out in your organization?
So many different directions I could go with that. I mean, I'll talk about access first, just because it's something I think about every day, but you have to design your front end, whether that's a phone number, a website, or a patient portal in a way that works intuitively, that actually works. So when you get on to make an appointment, you log off with one. And that sounds, how hard can it be? Very hard. But really working on design that makes us more consumer friendly, consumer accessible, convenient is really a very, very important word in that. So there's a lot of design work. And we're always learning and tweaking that, particularly when you talk to consumers themselves, which we do. They will tell you what works and what doesn't work, what flows and doesn't flow. But we're designing in so many different directions. The healthcare world is changing so much. Like so much of healthcare is now ambulatory. So how are you giving healthcare in communities where people are? I mean, in our area, you could see Brooklyn from here. I can literally look out my window and see Brooklyn. But to get from Brooklyn to here could be an hour and a half, 2 hours, and a lot of, and now with congestion pricing, more expensive than ever. So you got to be able to design healthcare and healthcare systems and facilities so that they're in Brooklyn or in Queens, where people are, so that they can get the care they need. And then you've got to have a hospital. I mean, hospitals are almost becoming big ICUs, right? So how can you design a hospital in a way that it's flexible, that the patient room is ready for many uses, not just one, that it's wired in a way that there's connectivity for the teams caring for them and for the patient, and maybe the people that are in the patient's lives that aren't in the hospital at that moment. So the room of the future is something we're doing a lot of thinking about, the patient room. The OR of the future, ORs are so different than they were even 10 years ago in terms of size and what's in them and how they're built. We're thinking about how AI is going to play a role. AI is the future. There's probably a lot of hype associated with it too. But we're already learning that, you can use AI to diagnose heart failure long before a clinician would see it. Just by looking at EKG strips, we're big. We have got tons of data. We can learn and use it and make the work that our clinicians do really the highest level of their skill and expertise. Imagine if you can intervene earlier in heart failure. What does that do for a patient and their outcomes and their quality of their life? So we're designing in sort of all different directions. In my role, I'm lucky. My colleagues really do see the value of patient-centeredness, and we weigh in a lot of different ways to make sure we're doing that, hopefully, in as sensitive and communicative and connected way as possible.
I love it. That's awesome. So I know the other organization that's close to your heart is the nurses, and particularly like your connection with Magnet. So I guess maybe talk about that a little bit. Like, give us a little bit of that perspective. What do you hear from nurses? How do you feel like you can lead them well in your role to help them embrace this future like you're describing?
Yeah. So I have the honor. It really is a privilege to serve on the Magnet Commission as the public member, the non-nursing member of the commission at ANCC, at the ANA, that confers Magnet designations on hospitals. It is such a rewarding volunteer experience for me every month to see what hospitals are doing. Doctors are obviously critical in healthcare. Nurses are the heart of healthcare. They absolutely are. My mom was a nurse, so I'm not even objective about that. I was raised by a nurse. Nurses also have an incredibly difficult job. Nurses are not only bedside caregivers, but they're translators, they're connectors, they're counselors, they're educators. And, in some of the world that I live in with like surveys like HCAHPS, which is the adult inpatient survey that CMS requires for patient experience, a lot of that falls on the nurse. And nurses have been through a lot the last couple of years. Post-pandemic environment, it's almost flipped where nursing was. A lot of people left the profession after COVID and the pandemic. A lot of new people have come in. So now we're in a situation where we have a whole new generation of nurses who are coming into the workplace who are newly trained and need to be oriented and trained and supported as they take up their practice. And the average age of nurses has come down. It was getting higher and higher. Now it's come down. But you also have a new generation that have different work expectations of the environment. And so you've got to think about how you make a workplace meaningful for a millennial nurse. It's a different generation, requires some different strategies. And in some ways, the millennials are teaching us something. I think they're teaching us that self-care matters. My generation, we tended to put that second, and there's a lot of good things we're learning from that new generation. The other thing we're talking a lot about at Magnet and the ANA and other places, nursing is not a line item. It is not a tool to be deployed. It is a core part of how we deliver care. And so nurses can't just be looked at as sort of a lever to pull. So there's a lot of talk about that, the return on investment of nurses, but also the fact that this is beyond money and FTE counting.
Yeah, absolutely. Wow. So maybe one more question. I'm going to turn over to Greg, give him a chance to ask a couple questions. So part of your role also, I know you had been active with Beryl Institute, talking to other people, colleagues in your profession and kind of sharing best practice. So I guess, what are you talking to them about these days? What does that sound like?
Yeah, the Beryl Institute, I'd encourage anyone who wants to learn more about patient experience to go to the Beryl Institute website. It really is the community of practice for patient experience leaders. I mean, years ago, we would talk about patient experience. We didn't even call it that. We called it, patient satisfaction. And it's way deeper than that. And there is a body of knowledge around how to understand patient experience and what you need to do to make it better. And the Beryl Institute, in many ways, is the compendium of that knowledge. And it's a great resource for people. What we're talking about at the Beryl Institute these days, and Jason Wolf is the leader of Beryl, he's a great guy and a wonderful leader, is really helping to reiterate and reinforce the value and importance of patient experience and the investment that is needed for patient experience to be meaningfully measured and improved. A lot of health systems struggle financially coming out of COVID. Some still are. And a number of them cut some of their PX resources. I think that that's a big mistake. You'll pay for that in other ways. And what Beryl and my colleagues and I have put together is a really great series of resources on what is the use case for PX? What is the expertise that you need to have in your organization? What's the investment you need to make to get that return on the experience? So I'd encourage people to visit the website and take a look at it.
Perfect. So Greg, you got questions for Rick?
I have a lot of questions I'd love to ask Rick. Rick, it's probably been 5 years since we spoke last, so it was a great pleasure in reconnecting with you. At New York Presbyterian, how is digital engagement supporting patient-centered care?
So we're doing tons in that area. You've got to be able, again, if you're going to provide good health care, you've got to be available to patients and customers in many modes and in the modes that they prefer. So, I think a lot of us before the pandemic, we're not really comfortable with virtual interactions. Now it's part of life, right? And so much of that has found its way into healthcare. And so we're trying to be a system that gets resources to patients in ways that are convenient to them. That's education about their condition, how to take care of themselves. That can be delivered multimodally. It can be the old discharge papers you leave the hospital with, but also sent to your portal. It can be multimedia, videos, etc. Some of our doctors record videos and send them to their patients so that they don't have to remember everything they just heard in that encounter. And then customers want choice. So there are times where I have a health issue and the only thing that's going to work for me is talking to a person live, having them have hands on me. There are other times where I don't want to, especially in New York. I don't want to travel to the office. I don't want to have to park or take the train. I want to be able to do what we're doing now, talk virtually or asynchronously. I want to be able to email my team and have that exchange. Maybe I don't need to talk to anyone. I just need someone I need to ask a question. So we're trying to be digital in all directions. Our CEO has said occasionally, like in some ways, hospitals, health systems are technology companies that provide healthcare. So you need to be able to design things in a way that patients and team members, not just patients, but how we even work together, can sort of choose how they want to engage with us and that option is there for them and readily usable.
That's a really good. I like that way of you meet everybody where they're at.
Yeah.
And that's really challenging. I personally prefer the electronic interaction to the extent that even though the health center is closer to me, I prefer to have that as an option because it does take a lot of time getting there, waiting in the waiting room, etc. But how do you address the challenges of getting staff, patients, and family members to adopt and use these new systems, especially some of the older folks?
It's surprising. I would have thought that it was, uptake of digital would have been lower in more senior populations. We're not seeing much of that. Now, we live in a very digitally savvy market. We've studied it. We're maybe a little more digitally savvy than other parts of the country. But really what you have to do is you've got to have, first of all, your teams have to understand how these things work, and it has to work in their workflow. So if you want a doctor or a nurse to use virtual, they have to be able to see, if I connect Rick virtually with the consultant we need on this case, that's going to make my day better too. It's got to work in all directions. Remember, we don't even talk about patient experience anymore. We kind of talk about human experience. Everyone in our walls is having an experience, including the people who work here. So if you want people to use it, your teams need to understand how it's used, and they need to see how it's going to make care better and also make potentially their practice better and easier. And then with patients, there's some that come to us saying, look, I do everything else digitally. Why the heck can't you people do that? But for those that are a little bit more reticent, you got to hold their hand and walk them through it. It's very rare that I find any patient that tries digital and then if it actually works for them clinically, doesn't want to do it again. But sometimes they need help logging on. And how do you create a password and how do you manage your portal account? And we do that. We help people with navigators and other resources.
Wow. One last question then, and then I'll turn back to Keith. In terms of the diverse populations that obviously you serve in the New York metro area, what are the big challenges in addressing folks of different cultures, different languages, et cetera? Is that an issue you guys are addressing?
Huge issue. So if a person exists on the planet Earth, they probably walk through our doors. For me, that's one of the greatest things about living and working in New York. I love that when I walk out my door every day, the world is there. Different languages, different cultures, different food. I find that enriching. And our health system believes that our diversity is a strength. It's not a weakness. It's a strength. Now, what does that mean in the day-to-day? You got to have services available in multiple languages. You have to have a robust interpreter services kind of service. And we spend millions of dollars every year making sure we interpreted last year for our patients in over 100 languages. So we need to be able to do that. And if you're on the phone with a patient, if that interpreter is needed, you have to have a system that gets that interpreter on the line stat.
Well, we did say at the Magnet facility, there was a vendor that leveraged AI for real-time language translation. Is that a emerging technology you guys are looking at?
Yes, absolutely. Back when I started in this business, an interpreter meant you called someone from an agency and they came in and stood by the bedside. Now, literally, we were doing that all over the place. Now, almost all of it is virtual. And so that's rapidly evolving. But the point is, you've got to have diverse services linguistically. You have to have staff that are trained to be culturally competent and sensitive. Essentially, that means people that are not making assumptions about people, but asking the right questions to learn about people. We train our staff to do that. You've got to have an organization that is really strong on diversity, inclusion, and belonging. We want everyone to feel like they belong in our doors. It's, again, faceted strategy. But if we can't handle diversity in New York, we can't do our business.
Wow. Thank you, Rick.
Yeah. So Rick, I want to wrap up here. So would you have any closing comments for our discussion today?
It was a pleasure to be with you. I hope sharing some of what we're doing is helpful to others. Like any place, we're proud of what we do, but we know we have work ahead and we're trying to get better every single day.
Yeah, well, this is awesome. This has been really great. I really appreciate you're challenging us too with all these complexities. I think we're really excited to maybe follow up with you again, maybe have you back in the future.
Whenever. It's good to be with you.
Great. Thanks again, Rick.
I especially like that comment about the human-centered design. I think that was a really powerful thought that I need to keep in the back of my mind.
Well, yeah, and even the idea that you've segmented, you've got the patient and the customer with your access. That's a really like a great nuanced distinction that, for an operation really that's critical.
Well, we got a lot of work ahead, but we're very committed to it.
All right. Well, thanks again, Rick. You have a great day.
Thanks, you both.
Take care. All right. Bye-bye.
Bye-bye.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.